Unit 6, Module 1 is Growth and Development of the Infant and Related Nursing Implications. Listed are the sub-competencies for this module. This goes along with your Maternity and Pediatric Nursing book, Chapter 25. Infancy refers to the period from birth through 12 months of age. During this time, growth, development, and maturation occur rapidly and simultaneously. When we discuss growth, we're referring to an increase in physical size due to rapid cell division. This results in increases in weight, length, and head circumference, which are objective and easy to measure at well-child visits. Development follows a predictable sequence, meaning skills emerge in an expected order. However, the timing is not uniform. Infants may experience brief delays or regressions, and the pace can vary based on heredity and environment. Overall, growth and development remain consistent and predictable over time. The gradual functional improvement of body systems that are immature at birth begin to mature. During infancy, all the systems, that includes neurologic, respiratory, cardiovascular, GI, hematopoietic, immunologic, integumentary systems, etc., continue to mature. For example, the anterior fontanelle, which is the soft, diamond-shaped area at the top of an infant's head where the skull bones have not yet fully fused, remains open throughout infancy, beginning to close around 9 months and completing closure approximately around 18 months. This allows the brain to grow rapidly during infancy. Many systems are immature at birth and continue to develop throughout the first year and beyond. The respiratory rate slows from about 30 to 60 breaths per minute at birth to 20 to 30 breaths per minute by 12 months. Infants are at higher risk for respiratory compromise because their airways are narrow and immune protection is limited. Respiratory development improves during infancy but does not fully mature until later on. The cardiovascular system also matures rapidly. The heart doubles in size during the first year. Heart rate gradually decreases from 120 to 140 to about 100, and the blood pressure slowly increases as the circulatory system adapts. Thermoregulation becomes more effective over time as peripheral circulation improves, helping infants better maintain body temperature. The GI system matures as stomach capacity increases and digestive systems develop. By around 5 months, infants are better able to digest more complex carbohydrates. Dentition is another visible sign of maturation. The first primary teeth usually erupt between 6 and 8 months, and by 12 months, most infants have 4 to 8 teeth. Growth in infancy is assessed by measuring weight, length, and head circumference at each visit. These measurements reflect physical and brain growth and are plotted on standardized growth charts to track patterns over time. Weight for length is also used to assess proportional growth and nutritional status. When interpreting growth charts, nurses focus on percentiles and trends rather than a single measurement. Percentiles compare an infant's growth to others of the same age and sex. A higher or lower percentile alone does not indicate a problem, but measurements should remain proportional and follow a consistent growth curve. Significant shifts across percentiles may signal illness or nutritional concerns and require further assessment. For weight, the average newborn weighs about 3.4 kilograms or 7.5 pounds at birth. An infant's birth weight typically doubles by about 4 to 6 months and triples by 12 months. For example, a baby who weighs 7 pounds at birth would be expected to weigh about 14 pounds at 6 months and around 21 pounds by 1 year. Length at birth averages about 50 centimeters or 20 inches and increases by about 50% by 12 months. Head circumference averages about 35 centimeters at birth and increases by 10 centimeters approximately during the first year. This reflects rapid brain growth at this time. These growth patterns are important benchmarks, especially the weight doubling and tripling during the first year. This table summarizes neurologic maturation in infancy by showing the expected timing of primitive reflex disappearance and the emergence of protective reflexes. Because the central nerve system is not fully developed at birth, infants rely on primitive reflexes that are present at birth and gradually disappear as the brain matures. As primitive reflexes fade, protective reflexes begin to develop and persist into adulthood, helping maintain balance and safety. The image shown here is demonstrating the Moro reflex, which is present at birth but normally disappears around 4 months of age. It's sometimes called the startle reflex. When a baby feels a sudden movement or hears a loud noise, the baby throws the arms out to the sides, opens the hands, and then brings the arms back in toward the body. This reflex is present at birth and normally disappears by about 4 months of age. This is just a brief overview for now, so this concept is covered or has already been covered in more detail in maternity. This image shows the pattern of motor skill development in infancy. Gross motor skills develop in a cephalocaudal pattern, meaning control progresses from the head downward to the trunk and then the legs. For example, infants will gain head control before they can even sit, crawl, or walk. Fine motor skills develop in a proximal-distal pattern, meaning control moves from the center of the body outward toward the hands and fingers. Infants first gain control of their shoulders and arms before developing precise hands and finger movements. So that's again cephalocaudal, head to toe, and proximal-distal is from the center of the body to the peripheral area. Gross motor development follows a predictable sequence, although the timing may vary. So by 2 months, infants can lift their head when prone, and they can move all 4 of their extremities. By 4 months, head control improves, and infants can hold the head steady and push themselves up on their forearms. At 6 months, infants roll from supine to prone and sit with support in a tripod position. This is generally when infants can begin sitting in high chairs but with support. They can also use their arms to push up straight. So at 9 months, infants could sit unsupported. Some may start crawling now or around the 10-month mark. If an infant still needs support to sit at this age, referral to a primary care provider may be indicated. So they should be sitting on their own at around 9 months. At 12 months, infants pull to stand and cruise while holding onto furniture. They may push large toys like those push-pull toys with wheels. That's appropriate at this age to support their gross motor development. It helps them with balance, strength, and coordination. Fine motor development involves increasing control of the hands and fingers and follows a proximal-distal pattern. That means movement develops from the center of the body outward to the hands and fingers. So this table from your book, Table 25.4, outlines the typical progression of fine motor skills during infancy, following a predictable sequence. So by 2 months, infants briefly open their hands. By 4 months, infants bat at objects, which means the infant is attempting to make contact or grab an object but lacks precise control. They can hold a toy when placed in the hand and bring their hands to the mouth. 4-month-old infants can hold a rattle if it is placed in their hand, but they do not yet fully grasp it on their own. By 6 months, infants can reach for a desired object. By 9 months, infants demonstrate a gross pincer grasp, using the whole hand to rake objects, and can transfer objects from one hand to the other. By 12 months, infants develop a fine pincer grasp, using the thumb and forefinger, similar to picking up a raisin. So this represents advanced fine motor control, and it's also why choking hazards must be considered. At this age, infants may also begin using a cup and spoon with assistance. More advanced fine motor skills, such as holding a crayon to make marks or stacking cubes into a tower, typically occur around 12 months and beyond. This is very important when selecting developmentally appropriate toys. Social development in infancy focuses on how infants develop trust, interact with their environment, and begin early cognitive understanding. During infancy, the primary psychosocial task, according to Erikson, is trust versus mistrust. Infants develop a sense of trust when their needs are consistently and predictably met. Trust is not about who provides the care, but about reliability. When infants learn that hunger, discomfort, and distress are responded to consistently, they begin to feel safe in the world. Infants are also in Piaget's sensory motor stage. They learn through movement, senses, and interaction with objects. A key milestone during this stage is object permanence, which is demonstrated when an infant actively searches for a hidden object, typically around 8 to 9 months. From a sensory standpoint, infants learn through touch and physical closeness. From Freud's perspective, infancy is in the oral stage, where pleasure and comfort come from feeding, sucking, and close physical contact. So the best tactile stimulation for a 3-month-old, let's just say, is cuddling and sucking, which supports comfort, bonding, and trust, according to Freud. Early vocalization follows a predictable pattern. Around 2 months, infants coo. By 4 months, they laugh and make simple vowel sounds. Babbling begins around 6 months, and by 9 months, infants string sounds together without meaning, such as mama. By 12 months, speech becomes meaningful. Infants attach meaning to words like mama and dada and can follow simple directions. Touch is a very important sense for communication. So, like we said, a 3-month-old probably best stimulated through cuddling, rocking, and sucking. So, touch is very important. It's normal for language development to briefly plateau when infants are focused on mastering a major motor skill, such as walking. Infants engage in solitary play, meaning they play alone and do not share or interact directly with other infants. Play during infancy is purposeful and coincides with developmental tasks, helping infants practice new skills. Play supports development psychologically and physically. It helps build coordination and perception of the environment. It's considered the work of the infant. Appropriate toys change with age to support developmental levels. So from about 1 to 4 months, rattles and mobiles with contrasting patterns support sensory and fine motor development. About 4 to 7 months old, age-appropriate toys would be fabric books and easy-to-hold toys that make noise. So around 8 to 12 months, toys that support movement and manipulation are best. So stacking cups, large blocks, balls, push-pull toys are all good. And then from a 12-month-old, the most appropriate play activity is probably the large push-pull toys because this promotes their gross motor skills such as standing, balancing, and cruising. Reading supports early brain and language development, so it's important to begin reading to the infant early on. When an infant is hospitalized, the best toy choice is the infant's favorite toy from home, as familiar objects provide comfort and security in an unfamiliar surrounding. Infant nutrition and feeding education are also guided by patterns of growth and development. Infants have high caloric needs due to rapid growth. Newborns require about 105 to 108 kilocalories per kilogram per day, which decreases to approximately 98 kilocalories per kilogram per day by 6 to 12 months. When discussing breastfeeding versus bottle feeding, nurses should emphasize that breastfed infants require vitamin D supplementation and rely on maternal iron stores during early infancy. Breastfed infants require vitamin D supplementation because breast milk does not provide sufficient vitamin D to meet the daily nutritional needs. Supplementation supports bone growth and should begin soon after birth. During early infancy, breastfed infants rely on maternal iron stores that were accumulated during gestation. These iron stores are typically adequate until about 6 to 9 months of age, after which additional dietary iron is needed to prevent iron deficiency. Formula-fed infants generally receive sufficient vitamin D and iron from these fortified formula, so supplementation needs will differ. Clear education helps caregivers understand why nutritional recommendations vary based on feeding method. For bottle feeding, caregivers should be taught to gently shake the bottle after warming, check and recheck the temperature before feeding to prevent any burns. Solid foods begin to be introduced around 4 to 6 months, starting with iron fortified rice cereal. New foods should be introduced one at a time every 3 to 5 days to monitor for allergic reactions. Safety teaching is essential. Honey should be avoided due to botulism risk, and cow's milk should not be given before 1 year old. Choking hazards such as grapes and popcorn should be avoided. Other nursing considerations that help with comfort, security, and prevention during infancy. So here are a few. When administering injections, holding the infant in the mother's arms provides comfort, reduces anxiety and distress, and supports the infant's developing sense of trust. So caregiver presence is a key developmental intervention during painful procedures. Having parents bring the infant's favorite toy or comfort item from home also helps reduce stress during hospitalization. Familiar objects provide security and continuity, especially since infants can't understand the reason for hospitalization. Oral health teaching should begin early. Parents should be taught to clean the infant's gums and emerging teeth with a soft cloth and to avoid putting the infant to bed with a bottle. This prevents early childhood dental caries and establishes healthy oral hygiene habits early from infancy. These interventions align nursing care with the infant's developmental needs while promoting comfort, safety, and long-term health. Developmental screening in infancy involves both parent report and direct observation. Nurses should ask parents whether a skill has been attained and also observe the infant performing the skill during assessment whenever possible. For premature infants, growth and developmental milestones are evaluated using adjusted age, not chronological age. Adjusted age is calculated by subtracting the number of weeks or months the infant was born early, so this prevents mislabeling normal development as delayed. Standardized screening tools are commonly used to support assessment and early identification of delays. These include the Ages and Stages Questionnaire, or the ASQ, which evaluates the infant's developmental progress. Parents complete this screening tool from 1 month to 5.5 years old, which assesses communication, gross motor, fine motor, problem solving, and personal and social skills. The Infant Toddler Checklist, or ITC, is a screening tool for children 9 to 24 months old, focusing on early communication, social interaction, and identification of autism or speech language delays. Infant Development Inventory, IDI, is another parent-completed screening tool for infants aged from birth to 18 months old, evaluating early motor, cognitive language, and also social development. So these are all important screening tools, and early screening allows for timely referral and intervention when needed. Unit 6, Module 2 will discuss appropriate health promotion activities during infancy and related nursing implications. The goal of health promotion is to support the infant's rapid physical, motor, and social development through anticipatory guidance and nursing interventions. The subcompetencies are listed here, and this also is from the Maternity and Pediatric Nursing textbook, chapter 25. These are the rest of your subcompetencies, which include other health promotion activities. Stranger anxiety typically appears around 8 to 9 months of age. At this stage, the infant recognizes that they're separate from others, so they may become clingy or cry when approached by strangers or unfamiliar people, even if the parent is present. In the hospital, to minimize distress, the nurse should talk softly and approach the infant slowly. The nurse should avoid sudden gestures that may startle the infant. If parents are present, stay within the infant's sight with the parent nearby to help the infant feel secure. Also remember that too much stimulation can overwhelm infants. Separation anxiety begins in late infancy. The infant becomes distressed when the parent leaves because they don't fully understand yet that the parent will come back. Over time, the infant will eventually calm down and engage with the current caregiver. The most important nursing intervention is to reassure parents that this is normal and a sign of healthy attachments. Attachment in parent-infant interaction is all about how bonding develops and how we can recognize it in real time. First, let's talk about forming bonds. So successful attachment is often observed through simple behaviors like eye contact, gentle touching, holding, and responsive vocalizations such as talking to the baby, soothing, and reacting to the infant's cues. These behaviors help the infant feel safe and supported, and they are signs that bonding is developing appropriately. Nursing assessment. If a parent appears to avoid eye contact with the infant, our priority is not to assume something is wrong right away. Instead, we assess for other attachment behaviors to determine the overall quality of the relationship. For example, are they holding the baby, comforting them when they cry, responding to their needs, or perhaps speaking calmly to them? Attachment can look different for different families, so we look at the full picture before drawing any conclusions. Limit setting and discipline in infancy and early childhood is about safety and teaching problem solving, not punishment. So the goal is to provide a safe environment while helping the child learn boundaries and appropriate behavior over time. In terms of strategies, parents should use a firm no for dangerous situations like reaching for electrical outlets, pulling on cords, or climbing something unsafe. Then we can redirect the child away from the undesirable behavior and toward a safer option. From a nursing perspective, our role is to educate, encourage, and praise the parent for taking action while reinforcing the importance of using no consistently. Consistency is what helps children learn. If no sometimes means no and other times maybe means maybe, they will keep testing limits. We also want parents to focus on redirection and maintaining a child-proofed home. Child-proofed home. The environment matters because children explore naturally, and preventing unsafe access is often more effective than constantly correcting behavior. So remember, misbehavior often reflects unmet needs like hunger, perhaps fatigue, insecurity, or needing comfort and warmth. So we always want parents thinking, what does my child need right now, instead of labeling the child as bad. So physical punishment or spanking should never be used. It does not teach problem solving, and it can increase fear and aggression rather than improve behavior. Thumb sucking and pacifier use are common in infancy, and sucking is actually a healthy, self-comforting activity. It helps infants soothe themselves, regulate stress, and settle, especially between feedings or during times of fatigue. From a nursing guidance perspective, we want parents to understand that pacifiers are fine, but they should not be used to replace needed food or parental attention. In other words, if the infant is showing hunger cues or needs comfort and connection, we should encourage parents to meet that need first rather than automatically give a pacifier to the infant. It's important to ensure good hygiene. Pacifiers should be kept clean, replaced when worn, and of course not shared between children. For safety, pacifiers should never be tied around the infant's neck with a string because of the risk for strangulation. If parents want to keep the pacifier close, they should use safe alternatives that are designed appropriately and always supervised. Finally, regarding weaning, it is recommended to begin weaning from the pacifier by about 18 months to reduce the risk of dental misalignment in prolonged oral habits. Teething and dental health start much earlier than most parents realize, so we want to focus on prevention and good early habits. For early care, even before teeth erupt, parents should clean the infant's gums with a damp washcloth after feedings. This helps reduce bacteria and builds the routine of oral hygiene early on. Eruption timing. So the first primary or deciduous teeth typically appear around 6 months of age. Once the teeth begin erupting, parents can use a soft toothbrush or a cloth with a smear of fluoride toothpaste to clean the teeth. A small amount helps protect developing teeth without using too much toothpaste. It's also important to remember developmental variations. While 6 months is the average, tooth eruption varies widely, so some infants may even have several teeth by 6 months, which can be earlier than expected, but still normal. Common teething symptoms include drooling, biting on hard objects, irritability, and occasionally a low-grade fever. Nurses should remind parents that teething discomfort is common, but if the infant has a high fever or appears very ill, it may be related to something else and should be evaluated. For dental visits, the American Academy of Pediatric Dentistry recommends that infants have their first dental visit by 1 year of age. This helps establish dental care early and supports prevention of cavities. For management, parents can offer a cold teething ring or gently rub the gums with a damp cloth to soothe discomfort. Major warning is to avoid topical anesthetics like benzocaine, such as Oragel, because of safety risk and limited effectiveness in infants. Finally, we need to teach prevention of bottle mouth caries, so infants should never be put to bed with a bottle of milk or juice. The sugar sits on the teeth and gums and can cause severe decay, even in very young children. For childcare options, the nurse's role is to help parents evaluate care based on the family's specific needs, licensing requirements, and overall safety. There's no perfect option for every family, so we focus on helping parents choose the safest and most appropriate setting for their child. In general, types of care can include center-based daycare programs, home-based childcare, or care provided by family members. Each option can be safe and appropriate, but each one comes with different strengths and concerns related to structure, supervision, and consistency. Key considerations when choosing child care include having low caregiver to child ratios, because fewer children per caregiver probably means better supervision and more individualized attention. We also want parents looking closely at cleanliness, infection control practices, and safety protocols such as hand hygiene, safe sleep practices, secure entrances, and emergency policies. Parents are encouraged to visit the child care setting ahead of time. This helps them feel comfortable with the environment, and it can also ease the child's transition by reducing separation anxiety and helping the child become familiar with the new setting and caregivers. During the first 6 months of life, the infant's primary source of nutrition should be breast milk or iron-fortified formula because these provide all the nutrients the infant needs for healthy growth and development. Breastfeeding has many important benefits. It provides strong immunologic protection, supports brain development, and promotes bonding between the parent and infant. In terms of nutritional needs, infants require a high amount of fluids. Newborns need about 140 to 160 milliliters per kilogram per day, and as infants get older, they typically need about 100 milliliters per kilogram per day. The infant may need more frequent feedings if he or she seems to be hungry all the time. We also want to teach families that infants should not be given supplemental water or any fruit juice in the first 6 months. Breast milk or formula is the appropriate fluid source at this age. If a parent discontinues breastfeeding before 6 months, let's say they stop at 5 months, the infant should be given commercial iron fortified formula, not cow's milk. Cow's milk doesn't meet infant nutritional needs and doesn't provide any appropriate iron. Finally, when parents ask about hunger cues, it's important to reinforce that if a young infant seems hungry all the time, the recommendation most likely is they need to increase the frequency of feedings rather than introducing solids early on. Solids aren't appropriate very young, less than about 6 months old, so frequent feeding is normal during growth spurts before then. When an infant is hospitalized, one of the best ways we can independently assess nutritional status is by daily weights. This gives us the clearest trend in intake, hydration, and the infant overall growth. During the second 6 months of infancy, breast milk or formula is still the primary source of nutrition even when solids are introduced. So if the infant is breastfed, they should still continue breastfeeding while solids are gradually added. There's also a decrease in caloric needs per kilogram of weight compared to the younger infant. Parents should be made aware of this need for decreased feeding times. A nutritional history assessment of an infant should include who feeds the infant, the types of fluids and foods not tolerated by the infant, and also their feeding pattern. When introducing solids, this typically begins between 4 to 6 months, depending on the infant, once the tongue extrusion reflex disappears and the infant can sit with support. So those are key readiness signs because the infant needs to be able to move food safely to the back of the mouth and swallow effectively. In terms of sequence, it's recommended to start with iron fortified rice cereal mixed with breast milk or formula. After that, parents can introduce pureed vegetables first, then fruits. This helps infants become comfortable with different flavors and textures. An important teaching point is to wait 3 to 5 days between new foods. So this can help identify any potential food allergies or insensitivities that may be presented by rash, vomiting, diarrhea, or other signs of intolerance. By around 8 months, infants can usually begin soft and mashed foods like peas or small dissolvable finger foods like Cheerios, as long as they're developmentally ready and supervised closely to reduce the risk for choking. Around 10 to 12 months, pureed or mashed meats can be introduced to increase protein and iron intake. So when we think about determining nutritional status in a hospitalized or ill infant, the best independent nursing intervention is, again, to weigh the infant daily. So daily weights are one of the most accurate ways to monitor hydration status, nutritional status, and overall trends in growth. To prevent obesity, one of the most important teaching points is that parents should avoid forcing the infant to finish the bottle or the entire jar. Instead, we teach parents to follow the infant's cues for fullness. Infants can self-regulate intake when they are allowed to stop when they're satisfied. We also encourage parents to hold the infant during feedings. This supports bonding, but it also helps the parent learn the infant's hunger cues, such as turning away, slowing sucking if they're full, pushing the bottle away, or becoming distracted. Another important point is to avoid fruit juice. So juice adds extra sugar and calories without the same nutritional value as breast milk, formula, or whole natural foods, as it can increase the risk for excess weight gain and dental issues. As the infant approaches 12 months, growth starts to slow compared to the first 6 months, so caloric needs per kilogram decrease. This is why toddlers often seem to eat less than parents expect, and we reassure families that this is normal. During weaning from the bottle or breast, we should inform parents that cow's milk is not recommended until the infant is older than 1 year. So before age 12 months, infants should continue breast milk or commercial iron fortified formula as their main milk source. If a mother decides to discontinue breastfeeding, commercial iron fortified formula should be introduced before 12 months. To support the transition, parents can introduce a sippy cup around 6 to 8 months. This helps the infant practice cup drinking early, even while they still primarily rely on breast milk or formula. A helpful strategy is to gradually replace one feeding at a time every 5 to 7 days, usually the midday feeding first, with a cup. So this makes the change less stressful for both the infant and the parent and increases success with weaning. An abrupt weaning process may cause infants to cry often, or they may excessively suck their thumb. So weaning should be done gradually. Regarding elimination, stool patterns vary greatly as the infant develops. Frequent stools are common in the first month, and gradually the frequency will lessen. Constipation may also occur later on because muscle coordination is still immature for the baby, so the parent should be informed that this may be normal. In terms of sleep patterns, newborns can sleep anywhere from 10 to 19 hours a day, but their sleep is usually broken up into short periods. By about 12 months of age, infants typically sleep around 9 to 12 hours at night, along with 1 to 2 naps during the day. Although this can range, infants typically sleep through the night around 3 to 4 months. One of the most important teaching topics is that infants should always be placed on their back to sleep to reduce the risk of sudden infant death syndrome. The sleep surface should also be firm and free of loose items. That means no pillows, blankets, stuffed toys, or anything like that in the sleep space, because these increase the risk of suffocation. By around 4 months, parents can begin establishing a consistent bedtime routine to help infants learn to self-soothe. A calm and quiet environment is helpful. Swaddling must be discontinued as soon as the infant shows signs of being able to roll over. A predictable routine helps infants transition into sleep more smoothly and supports longer stretches of nighttime sleep. We encourage parents to continue routines and comfort measures that are already used at home if the infant is hospitalized. Familiar patterns help decrease stress and support rest. In the hospital setting, nurses should cluster care whenever possible so infants can have longer, uninterrupted periods of rest, which supports growth, healing, and overall development. Now let's focus on safety and injury prevention, which is one of the most important parts of infant nursing care. So for car safety, infants must be in a rear-facing car seat in the back for the entire first year, and much more beyond. Rear-facing provides the best protection for the infant's head, neck, and spine. For home safety, parents should use safety gates at the top and bottom of stairs and use outlet covers and cabinet locks to prevent falls and electrical injuries or poisoning. One key age-specific risk to remember is that for infants aged 1 to 6 months, the most frequent type of accident is suffocation. This reinforces why safe sleep and a safe environment are critical. So parents should identify and avoid choking hazards like small toys or other objects, even small hard foods. Keep toxic substances out and locked away, like cleaning products and medications. Put them completely out of reach. Avoid pillows and cushions. Any crib toys with strings should also be removed. Water safety is also another important teaching point. Infants should never be left alone in a bathtub or near a pool, not even for a second. Drowning can happen very quickly and silently. And lastly, in the clinical setting, if an infant has an IV site secured, the nurse must carefully assess circulatory status in all extremities. We want to monitor for swelling, any coolness or discoloration, delayed capillary refill, or decreased pulses. We want to do this often to prevent injury related to the stabilization materials or infiltration of the needle itself. Last part of this module focuses on education priorities and community resources that nurses can use to support families. So for priorities, anticipatory guidance should focus on the next stage of development, not only about what the infant is doing currently. So we teach parents what to expect next and how to prepare. For example, if you have a 4-month-old infant, you would start educating parents about baby proofing for crawling, for example. Because that milestone is approaching quickly and safety risk will increase once mobility begins. For resources, nurses should always know what community supports are available and refer families when appropriate. So WIC is a key resource for nutritional support, including access to infant formula and healthy foods. La Leche League is a great resource for breastfeeding education and ongoing breastfeeding support. And then the health department is an important resource for immunizations, routine screenings, developmental screenings that help identify delays early and can connect families with early intervention if needed. Unit 6, Module 3 is Nursing Care of the Sick Child. We'll talk about pediatric nursing in both the hospital and community settings. Please review your sub-competencies for this module. Your reading is Chapter 33 from your maternity and pediatric nursing textbook. Illness and hospitalization are stressful for children and families. Common stressors for children include anxiety, fear, separation anxiety, and loss of control. Anxiety and fear often come from unfamiliar environments, painful or invasive procedures like inserting an IV, and also not knowing what to expect. Hospitals can feel overwhelming, especially for children who have limited understanding of what's happening. While nurses should acknowledge feelings and provide age-appropriate explanations, unnecessary delays of required procedures can increase anxiety. Prolonged anticipation often makes fear worse rather than better. Separation anxiety is one of the most significant stressors for children, but especially for infants and toddlers. Being separated from parents and familiar surroundings causes distress and is the most stressful aspect of hospitalization for many children. Loss of control is especially significant for school-age children. Hospitalization disrupts routines and independence, which can increase anxiety. Children at this stage may try to cope by delaying or negotiating procedures. Parents are also affected by their child's hospitalization. The most common initial reaction parents have to their child's hospitalization is fear. Understanding these stressors helps nurses provide developmentally appropriate, family-centered care. When caring for a hospitalized child, safety and physical care are always top priorities. Maintaining a secure environment is essential to prevent injuries and complications. Nurses must follow strict safety protocols, including ensuring that the child always has proper identification and monitoring closely to prevent falls from beds or cribs. Crib safety is especially important. Side rails should remain up at all times, and for infants or toddlers who are at risk of climbing out, a clear plastic crib, such as the one shown in this image here, cover may be used. Restraints are used only as a last resort and only when necessary. When restraints are required, they must be the least restrictive option and closely monitored to protect skin integrity and circulation. Safe transport is another important responsibility of the nurse. Nurses should use age-appropriate methods like wagons with high sides, strollers with safety belts, or even carrying infants using a football hold. So in addition to environmental safety, physical care includes safe medication administration, which we'll discuss in another slide. Also close monitoring of IV sites. So nurses must assess for signs of infiltration, such as coolness, taut skin, or blanching at the venipuncture site. Overall, priorities of care for the hospitalized child include completing a thorough admission assessment, orienting the child and family to the environment, supporting the family, and ensuring safety throughout the hospital stay. Infection control is a critical priority when caring for hospitalized children. Children with known or suspected infectious diseases, those who are immunocompromised also, may require isolation to prevent the spread of infection. Nurses and visitors must use appropriate PPE or personal protective equipment like gloves, gowns, masks, based on the required precaution. perhaps even goggles. Because PPE can be frightening for children, nurses should explain its purpose and, when possible, allow the child to see the nurse's face before a mask is applied to reduce anxiety if it's possible. Fever management is another key aspect of nursing care. So antipyretics such as acetaminophen and ibuprofen are commonly used in pediatric patients. The primary reason for treating fever with antipyretics is to prevent hyperthermia and also the increased metabolic demands associated with elevated body temperature. Nurses are responsible for ensuring accurate weight-based dosing and monitoring the child's response to prevent toxicity or adverse effects. Nutrition and hydration support healing and comfort, so maintaining normal feeding routines whenever possible helps promote a sense of normalcy for the child. Some children may require specialized nutritional delivery method, such as portable feeding pumps to allow mobility. So before discharge, nurses have to provide clear teaching regarding dietary needs, fluid intake, and any special nutrition requirements for home care. These interventions support both physical safety and emotional well-being while promoting recovery and continuity of care. A key role of the pediatric nurse is helping to minimize stress related to illness and hospitalization. Promoting coping and comfort is necessary for both the child and the family. Preparation for procedures helps reduce fear of the unknown. So nurses could use age-appropriate explanation, if allowed, if the child is able to understand, and also allow children to see and touch equipment such as the stethoscope or mask before it's used. Play is a powerful therapeutic tool. So therapeutic play allows children to express their feelings and gain a sense of mastery. Perhaps needle play with a toy needle on a doll, for example, helps children work through fears related to injections or procedures. Minimizing separation is important, especially for young children. Parents should be encouraged to room in and participate in daily care, such as feeding and bathing if they're able to. Familiar routines and caregiver presence help reduce anxiety and promote trust. The room environment also matters. So using a safe zone approach means avoiding painful procedures in a certain child's bed area or play area that's designated to help the child maintain a sense of security in those spaces. Comfort measure should always be developmentally appropriate. For infants, for example, techniques can be swaddling, sucking, gentle motion, which are highly effective. Allowing children to keep their favorite toy or blanket supports coping by providing familiarity and security. Throughout the care, nurses should involve the parents, maintain routines, encourage age-appropriate independence, and use therapeutic communication. Open-ended questions help parents express their feelings, and empathy strengthens the nurse-family partnership. So all of these interventions work together to reduce stress, help improve cooperation, and support healing during hospitalization. Pain assessment and management in pediatric patients should be one of the main priorities. Because infants and young children can't reliably self-report pain, nurses have to use developmentally appropriate assessment tools. So for infants and nonverbal children, usually less than 3 years old, we use the FLAC scale. So FLAC stands for face, legs, activity, cry, and consolability. Each category is scored from 0 to 2, with the higher score indicating increased pain in that category. Nurses should observe behavioral cues such as facial expressions, the leg movement, activity level crying, and consolability means how easily the child can be comforted. These observations guide clinical decision making when verbal communication from the child isn't possible. Pain management involves pharmacological and non-pharmacological interventions. Tylenol and ibuprofen, again, not just for fever, but this can also be used for pain and is quite often ordered for pediatrics patients. So medications should be administered as prescribed. Comfort measures, as we discussed before, swaddling, perhaps distraction, maybe there's some toys they can play with. Caregiver presence could be used also whenever appropriate. So untreated pain in the child can lead to negative physiological responses. If in infants and children experiencing pain, nurses often see increases in heart rate, respiratory rate, and blood pressure as well. It's important to recognize that children do experience pain, but it's frequently undertreated. So accurate assessment of all of these that we just mentioned and timely intervention are essential to promote comfort, healing, and safety for the pediatric patient. For children older than 3 years, pain assessment can be self-reported. The Wong-Baker-Faces Pain Rating Scale is commonly used in this age group. The FACES scale allows children to point to the face that best represents how much they hurt, ranging from no pain to worst pain. This tool is effective because it matches the child's developmental ability to recognize and describe feelings using visual cues rather than numbers. So when children are able to self-report pain in this way, nurses should also include other physiological indicators. As we said, when a child is experiencing pain, expected findings may include an increase in heart rate, respiratory rate, and blood pressure. So we use both the child self-report and objective cues to allow a more accurate pain assessment so we can provide timely, appropriate pain management. When developing a nursing care plan for the pediatric patient, nurses follow the process of ADPI, so assessment, diagnosis, planning, and implementation, and then evaluation, of course. Each step must be developmentally appropriate and family-centered. Assessment is the foundation, so this includes a thorough physical assessment and relevant history. For infants, documenting the birth history is essential, including prematurity or perhaps delivery complications. Other ongoing assessments should include monitoring of the IV site, vital signs, intake and output, and comfort. Based on assessment findings, nursing diagnoses are identified. Some common ones for pediatrics include anxiety related to the hospital environment or upcoming procedures, powerlessness, perhaps related to the healthcare environment and loss of control, interrupted family process, Deficient knowledge are others regarding the diagnosis. Risk for caregiver role strain is also another one. So this planning phase, the planning phase focuses on setting goals that promote safety, comfort, control, and age-appropriate development. So the goal for the interventions should aim to minimize stress, support coping, and maintain routines whenever possible. So implementation involves carrying out interventions in a way that builds trust and reduces fear. So for toddlers, physical exams perhaps should be performed while the child sits on the parent's lap. Children should be allowed to touch and examine equipment before procedures. Therapeutic play could also be used to help them process fear. Transitional objects such as a favorite blanket or toy should be encouraged as they provide security in unfamiliar environments. Nurses should use open-ended questions and empathy to support parents and strengthen the nurse-family dynamic. Throughout care, accurate teaching is essential, so nurses must ensure caregivers understand procedures such as medication administration, temperature assessment at home, specimen collection if needed. Discharge planning begins on admission and includes assessing family readiness, especially if a child is sent home and perhaps like on a ventilator, and the child will be technology dependent. So parental willingness and ability are critical for safe and effective home care. This structured, family-centered approach supports safety, comfort, and continuity of care for pediatric patients. Medication management in pediatric patients requires precision and vigilance. All pediatric patients must be calculated using accurate weight-based dosing to prevent underdosing or toxicity. It should be very precise. That's why we typically don't round when we do dosage calculations for pediatric patients. Common medications you will frequently see include antipyretics and analgesics, as we mentioned, acetaminophen or ibuprofen. Antibiotics like amoxicillin, ampicillin, ceftriaxone, Unicin, vancomycin, azithromycin are pretty common, and corticosteroids like prednisone. Nurses are responsible for understanding each medication's action, contraindications, and required assessments. For example, vancomycin requires close monitoring of trough levels. So these are lab levels that must be drawn, and as well as renal function. So this is important to know before administration. The administration of medication should also be developmentally appropriate. So for example, infants who need PO liquid medications should be given the meds using a syringe without a needle, slowly instilled into the cheek pouch to reduce the risk of choking. So metal spoons, medicine cups, or placing the syringe in the back of the mouth are definitely not good practice and should be avoided. This should also be taught to the parent as well. Routes of administration may include eye drops, IV medications, IM medications, oral liquids, etc. When administering eye drops, nurses should stabilize their hands on the child's forehead, pull down the lower eyelid, and place the medication into the lower conjunctival sac. IV medication administration requires careful site monitoring, as we mentioned, so very important to know. Some signs to note are cool, taut skin, blanching at the site, as this could indicate infiltration, so this has to be addressed promptly. Education is a critical nursing responsibility, so before discharge, caregivers have to be taught the correct dose, route schedule, and potential side effects of all medications.